Dementia is also something that can mimic other conditions. How many times have I seen the patient whose cognitive problems are solutioned with hormone replacement? It's menopause, not Alzheimer's, is the problem. Or ADHD in a 40-year-old woman who's juggling her career and her kids and can't find her car keys and thinks she has Alzheimer's when basically she just has attention deficit and needs more sleep and maybe a little Vyvanse.
This is the Visible Voices podcast. I'm Dr. Resa Lewis, emergency medicine and lifestyle medicine physician, medical educator, and your host. If you're new here, this show is about making healthcare more equitable, one visible voice at a time. Today, Dr. Lucy McBride joins. Lucy is a physician who's practiced primary care medicine in Washington, D.C. for over 2 decades. She's a native Washington, D.C.er, a Princeton and Harvard Med School graduate, and trained in internal medicine at Johns Hopkins. Lucy and I share a belief that medicine works best as a relationship, not as a transaction. She writes a newsletter, Are You Okay?, and hosts her own podcast, Beyond the Prescription. She's dropped her first book, Beyond the Prescription, a framework for reclaiming agency over your health. Dr. Lucy McBride, welcome to the Visible Voices podcast.
Resa, thank you for having me. I'm delighted to be here.
So Lucy, take us back to when you decided it was going to be primary care. Why primary care?
I realized early on in my training that I loved understanding the whole person, that health was about more than just people's lab tests, and that the context mattered, that people's lives, their biases, their preferences, the social determinants of their health mattered as much as the blood test did. And so I wanted to do primary care. It was rooted in relationships, understanding, and building rapport.
You've shared this great story that we're not only physicians, but we are patients, and we have agency as patients. In fact, this is a lot of the content of your book, but I want to start with a story. Appendix, bagel, gangrene.
I love that you pull that story, Resa. So I had appendicitis 1 month after my first child was born. I was in my residency at Johns Hopkins, and I went to the ER. I kind of knew what was happening. I had that classic right lower quadrant pain. They scanned me. Appendicitis was diagnosed. They said, we'll tee you up to go to the operating room. Don't eat anything by mouth, right? So I just got wicked hungry. I was nursing Henry, and I just decided that, I don't know. My mind went out the window, and I ate a bagel. So they were about to take me into the OR, and they're like, when was your last food? And I said, oh my God, I had like crumbs dripping off my chin. I'm like, just a minute ago. And so they had to postpone my surgery. And by the time the surgeon got in there, he said that my appendix was gangrenous. I'm lucky that I didn't get septic. The point of that story wasn't to tell people what a fool I am, although I am in moments, is really to say that I am you too. Like, I have been a patient. I have been a patient where I am my own worst enemy.
Thanks for that story. And what I really like is that your book that we're discussing today, Beyond the Prescription, is chock full of stories, your own as well as those of your patients, as excellent illustration for what you're trying to teach the audience. Before we go granularly into the book, 30,000-foot view, you have a newsletter, Are You Okay? Yes. 40,000 subscribers. You have a podcast, Beyond the Prescription, same book title. Why do you think it's important that we as physicians need to have our voices written, audio, and visual?
Because people are exhausted and don't know who to trust and don't know who to ask for help. They don't know who to ask basic questions to, like, should I get a COVID shot? Or should I pursue chemotherapy or radiation? We're living in a trust desert. People don't know who to trust. The CDC, their doctor, ChatGPT, the influencer on social media. I felt an obligation, if you will, even though I'm humble about what I don't know, to take the 25 years of patient care, 20 plus years in primary care, and talk about the special sauce that happens between me and a patient to empower them to make healthy decisions for them, and take that special sauce and write it down and put it out there. Because most people in this country don't have time with a doctor. They don't have time to even get through their lab results, not to mention talk about how their grief, their stress, their caregiving has to do with their eating, their exercise, their sleep, which has to do with their blood pressure. They don't have that luxury, and it shouldn't be a luxury. It shouldn't require tons of money to have access to a deeper understanding of what health is and how to ask better questions. My book is really, trying to take the lessons I've learned beyond the walls of my office and hand people a sense of agency over their health to bring to their own doctor, to bring to their computer keyboard when they're sitting in front of ChatGPT.
This is just the perfect example of healthcare design where the end user, the patient, the person is at the center of the healthcare process. You mentioned trust desert. We know that there are health deserts, there are food deserts, there are maternal health deserts. And you mentioned chat and AI. And so where right now is AI playing a role in your work?
I think AI is coming for medicine. It's already here, right? And it offers great promise if it's harnessed in the right way, and if it's shepherded by people who understand what care is. That care for a human being is a uniquely human endeavor. There's no AI that can put your hand on someone's shoulder when they are telling you that they've lost their spouse and they're struggling with grief. There just isn't. There's no AI that can integrate across different domains and understand how someone's arthritic knee affects their pain medications, which affects their stomach acid, and there's heartburn, which affects their cough, which keeps them up at night. I mean, you just can't have that. If you think about it, AI is this master, answer generator. It is great with answers. We have an answer to everything, right? And that's wonderful for people who don't have access to a doctor. But the skill is asking it the right question, right? And so we become, I think, as physicians, more valuable as the people who are asking the appropriate questions. Health isn't about having all the answers. It's about asking the right questions of yourself and of the people responsible for your care. And that requires training, that requires expertise, that requires understanding human being. To answer your question about how I use it now, I mean, I dictate my patient notes. I dictate, after the patient goes, I dictate a note, and then AI generates this beautiful summary letter to my patient. So they have a summary of our visit that's not me, hunting and pecking on a keyboard. It's shaved lots of hours, I think like 2 hours off my day.
Wow.
Because I believe strongly in handing people a written documentation of what we discussed. So they aren't walking out the door and parking and getting into their car after our visit and thinking, what the hell did she just say? And then I use it for back office things, but always with human oversight. But it is a wonderful thing. I mean, in many, many ways, I'm not great at dermatology. When someone comes in with a rash, I mean, if it's shingles, if it's eczema, if it's tick bite, I'm good. But for the generic rashes, I don't always know. So I will ask ChatGPT, or open evidence, really. And, I will tell the patient I don't know what I don't know. So let's look this together and then send you to the dermatologist. I think it's helpful in many ways, but it's not a substitute for human relationship.
Wearables, like either a ring or a watch, even a device, for example, to monitor someone's sleep apnea.
I think wearables are having a moment for a reason. One is the obvious, that I think people want information, they want data, they want to see their interiority on their body, right? They want to track their steps, they want to track their apnea. I think it's wonderful. I had a patient whose atrial fibrillation was diagnosed by his Apple Watch. Great. I mean, he had been called anxious by his cardiologist. And he was anxious, but he was anxious largely because he had atrial fibrillation that wasn't being captured, and his Apple Watch caught it. I think the reason these wearables are so popular is, one, because people want agency over their bodily signals, but two, because doctors don't have time to countenance all of that kind of information. And there's just no way to track people's metrics, as physicians. And I think it also speaks to the idea that people don't have access to a physician. They don't have access to care. So when people are feeling, who's my doctor, who's taking care of me, it's much easier to put your trust in a device than it is a human being who doesn't answer the phone or can't see you for 3 months, right? So I think that the explosion of these devices is an example of, medicine not being able to spend time with people through no fault of doctors, but through the fault of the system, to say, let's talk about, exercise and how exercise might affect your mood, your sleep, your diabetes. So people are finding that out on the internet and then taking matters into their own hands, which is good. It's just that in general, it's just that two things. One, these devices become sometimes like the bad boyfriend. I see patients all the time who feel surveyed and judged so much by their devices that they are, feeling worse. Like one of my patients had insomnia because she was so worried about pleasing her sleep tracker that she just couldn't sleep. And I'm like, why don't you just ditch it? And she finally slept. But also I think there's an ease with which people assume that data equals health, right? That if you get 10,000 steps, if you eat this much protein, if you get this many hours of sleep, you're healthy. But data alone doesn't equal health, right? You can be a step tracker, a sleep tracker, and still have depression, still have atrial fibrillation, still have undiagnosed cancer. You need data is only one part of the way in which we define health.
Your clarity, I love, and this down-to-earthness reality about healthcare, about patients. You have talked about and written about normal and measuring health by someone else's standards. And this is sort of exactly what I'm dovetailing off where you just shared. Let's talk about normal lab values and what's the problem with this concept of normal.
I just wrote a piece for Katie Couric's, her like industrial complex about this. And I talk about it all the time. Like labs are only one part of your health picture. Take perimenopause, a perfect example. Patients come in all the time. I don't feel well. I have brain fog. I have irritability, insomnia. I don't feel like myself. And they ask me to check their hormone levels. So sometimes I will, and we can talk about that separately. But if they come back normal, and this is often why I don't check hormone levels, it doesn't mean you're not in perimenopause, right? It doesn't mean that your hormones aren't shifting minute to minute and are responsible for feeling not like yourself. There's a limitation on lab results. I mean, this is why we go to medical school, right? Is to understand how to interpret labs and how the patient, the totality of the patient is not defined in a blood test. You can have two different people with the same LDL cholesterol. Both are in the normal range, depending on what lab you're looking at. But for one person, that is actually way too high. For another person, it's completely normal. In other words, the goal cholesterol for you hinges on your other risk factors for heart disease, the presence or absence of known cholesterol plaque in your arteries, and other factors. So, this is why hopefully you and I will always have a job, is because data in a vacuum is just data. And so I think, what a lot of people are seeing, especially in this era of like doctors having 15 minutes max, the studies show that doctors interrupt patients in 11 seconds, the first 11 seconds, is that people are going out and getting their own labs, right? You can now order your own labs. Or they go to a doctor and the doctor doesn't have time to sort of think creatively beyond the normal set of labs. And they say, you're normal. The patient feels dismissed and they go on the internet and they're like, what the hell is wrong with me? Through no fault of physicians, it's the system that is so broken that it doesn't give doctors the time and space to understand the context, the patient's story, their irregular periods, their mood swings that are, by definition, perimenopause, even with normal labs.
Circling back to the book and sort of patients being advocates for themselves or being partners with their physicians and other healthcare professionals. 4 quadrants are informatics, inputs, infrastructure, and insight. I like the alliteration of all eyes. So I'm wondering if you can give us sort of the brief on each of them. Yeah. So informatics.
So the point of the point of the 4 quadrants is to show people that health is an ecosystem. Your health is conceptualized for many people, doctors included, is like your set of lab data, just your hard metrics. When health is actually the interrelationship between your different quadrants, right? Like, so the quadrants are informatics is information. It's biometric data. It's also your biographic data. It's your cholesterol and your blood sugar. It's also biographic data like, were you raised in poverty? Were you, the child of an alcoholic parent? Were you bullied on the school bus for your weight? Those are pieces of data that have everything to do with the rest of your ecosystem.
Very clear. Next, inputs.
Inputs is everything you put in your body. Everything you eat, drink, ingest. So vitamins, supplements, of course, food, alcohol, recreational drugs, everything you ingest, whether it's, quote, natural or pharmaceutical or legal or illegal, something you're habituated to using or it's new to you, those things matter. And they affect your informatics. They affect your data. And conversely, your biographic data affects your relationship with alcohol, your relationship with food. So your inputs are everything that goes into this system.
The ecosystem is becoming full. Next, infrastructure.
Infrastructure is the vehicle that carries you through life. So we all have this container, right, that holds all of our organs, our skeleton, our muscles, our bones. And unlike your Honda that you can trade in, right, you can't trade in your whole skeleton. So you need to take care of it. People take care of their cars more than they do their skeleton. I think physical therapy is such an underutilized resource. We default to sending people to the orthopedic doctor when the muffler's broken and get a new muffler, when actually there's so much you can do to maintain your skeletal health to drive you through life. When I talk to my patients in their 80s, they're not looking to kind of optimize their, this and that body parts. They're looking to be functional and mobile, to be able to walk up and down the stairs without pain, to be able to sleep without discomfort, and ultimately to understand what their skeletal vulnerabilities are and where they need to work on them. I mean, that's true for everybody, but I think we take our skeletons for granted when we're young and active, and our skeleton deserves its own quadrant because it's that important.
The final quadrant is insight.
Insight is, to me, the most interesting. It's about it's about anxiety, it's about mood, it's about relationships with food, alcohol, other people, work, self, your doctor. It's about mental health. It's about acknowledging that, do I have anxiety? It's not the right question. It's where do I live on the continuum of anxiety? We all have anxiety. It's not a question of are you anxious or are you not? It's where do you live on the continuum of anxiety when things are quiet in your life? And how far up that continuum do you travel when life gets hard? Is your baseline level of anxiety comfortable, or is it interfering with your inputs? Your pain medication you take for your bum hip. It's about the unconscious biases that we bring to our health and to our life. I have a whole chapter about the patient personality where I've broken down, it's where I talk about these sort of 4 archetypes of patients as a way of helping people reflect, hold a mirror up to themselves to help them understand, like, what version of themselves do they bring to the doctor? Are you the pleaser who wants to win the appointment? Are you the person who's the sort of denier, like, it's all fine, no big deal? Are you the person who just wants the prescription and the pill and not to understand the why or the mechanism? None of these are indictments of people. They're not actually your whole personality. It's just I obviously have a bagel eating personality in the face of doctors. But the point of the insight quadrant is on self-reflection and to understand that you have a whole landscape in your body of information to bring to your experience of getting healthcare, of communicating your needs and receiving care back. And that requires insight.
When you and I first met, you were transitioning to a new structure of your primary care practice. And I'm wondering what your clinical practice looks like today. And I'm interested in age because you're very particular about talking about having a health span more than a lifespan.
I've learned the most, you learn a lot in medical school and in training, but at the risk of sounding cliche or kind of like hokey, like I've learned the most from my older patients. I've learned the most about wisdom. I mean, to me, health, Resa, at the end of the day, health is like a version of the Serenity Prayer. It's about understanding where you have agency and where you need to cede control and knowing the difference. In my older patients, because they had to or they wanted to, have had to reckon with health issues, loss, vulnerability, where they don't have entire control, right? If you have a cancer diagnosis, you can't control, that happened to you. You can control, though, how you decide to treat it, what decisions you make, and how you handle adversity. And so my patient population tends to be, I see, I think it's funny that the doctors tend to see patients, or patients tend to gravitate to doctors who are about their same age or a little older. I think I was born like an 80-year-old, so I have a lot of older patients, and my Substack readership tilts older. Now, I don't know if that's because people who are older have more time to read and respond back, but I've actually done some polling, and my average reader is like 65 and up, and I have men and women. I don't know if that answers your question, but like I think I gravitate to older patients. I think they gravitate to me because I think I'm not the doctor who's going to try to tack risk down to zero when A, that's not your goal, and B, there are unintended consequences of trying to tack risk down to zero. In other words, like I just wrote an article for Maria Shriver this weekend about hormone replacement therapy after menopause, and how the question isn't, can I take hormone replacement therapy? It's what are the risks of it and what are the risks of not taking HRT? It's about risk mitigation and risk assessment because there's risk lives on both sides of that decision.
Dementia. Cognitive decline, brain health. It's actually Brain Health Month. It's also Gun Violence Prevention Month. Because your patient population skews older, what are the common conversations you're having with your patients in terms of prevention, treatment, and reversal? Although I know the reversal piece is quite limited.
So it's a question that comes up all the time, whether it's my older patients who are saying, I'm worried about my cognition, whether it's a spouse coming in saying, I'm worried about my wife's or husband's cognition, or it's a middle-aged person who's concerned about their risk for dementia because they have just cared or are caring for an older parent with dementia. The beautiful thing about dementia prevention and cognitive care, if you will, is that there are so many modifiable risk factors that people often don't realize. Jonathan Rosand at Mass General Hospital has created this scoring for brain care. So it's called the Brain Care Score. You can go online and look it up and you can take your score. The higher, the better. What the Brain Care Score tells you is what I talk to my patients about, which is that you have more control over your brain health than you may think. So many patients think that it's in the stars, that it's destined to happen because their family member had it, or that they just have very little control over their brain health. When in reality, cutting back on alcohol, getting more exercise, prioritizing sleep, social connection, avoiding loneliness, there's so many things you can do to actually improve your cognitive health. Now, that's not to say I don't also treat people with active Alzheimer's. I have patients with Alzheimer's. I have patients with frontotemporal dementia, and the landscape is really emerging and rapidly accelerating. We have these new medications that are anti-amyloid to help people reverse some of the amyloid plaques in the brain. We have more sophisticated testing, blood testing and imaging for early detection and potential treatment. Dementia is also something that can mimic other conditions. How many times have I seen the patient whose cognitive problems are solutioned with hormone replacement therapy? It's menopause, not Alzheimer's, is the problem. Or ADHD in a 40-year-old woman who's juggling her career and her kids and can't find her car keys and thinks she has Alzheimer's when basically she just has attention deficit and needs more sleep and maybe a little Vyvanse.
When I moved from training in Boston to practicing emergency medicine in New York City, it was the first time I really saw how many people come to the emergency department for what were seemingly primary care chief complaints, signs and symptoms. I'm wondering, from your perspective as a primary care doctor, what does that access gap, that primary care physician access gap look like?
It resonates so much, Risa. One of the reasons I went into primary care was because when I worked in the ER at Hopkins after I finished my training, we were basically primary care for East Baltimore. So I was seeing patients with urinary tract infections and sepsis who just needed vaginal estrogen to prevent the UTI. I saw patients who just needed an insulin refill, but they were in the ER for an insulin, diabetic crisis. Graduates of medical schools aren't deciding to pursue primary care fields because they see the landscape out there. They see that primary care physicians, whether it's internal medicine or family medicine or pediatrics, are being forced to see patients every 10 or 15 minutes. They're not getting paid what other specialties are getting paid. And then I think there's the fact that young people these days don't love the relationship as much as we did, but I don't know if that's true. I think that may be unfair to the younger generation making that characterization. But I think fewer and fewer graduates of medical schools are going into the primary care professions. And then you have an aging population. You already have a shortage of primary care doctors out there. And so a lot of doctors are doing what I did, which is leave the insurance system and build your own practice, where patients can submit their bill for out-of-network benefits. And it's not that I only see rich people. I mean, of course, there's a privilege factor there, of course, but I see people who just prioritize their health. They can still use their insurance. They do use their insurance for all the things. They want someone who will spend an hour with them. I just saw a patient last week who's 80, who just lost his wife. He's on 10 medications for his heart failure, for his diabetes. He's got a bomb hip and he's grieving. I mean, you cannot care for that person in any meaningful way in 10 minutes. You just can't. So it means I can have fewer patients altogether and have more time, which is ultimately, that's what patients want and that's what doctors want.
You can care for patients with those restrictions, but I think one of the results, the consequences, is moral injury that doctors end up with. I really do.
I do think that's why people leave medicine. I don't think that physicians leave medicine because they don't care about people. I think it's that they do care about people. I think it's that because we care about people, you feel inadequate and you feel a hurt in your heart when you cannot take the time to see a patient. I mean, a lot of primary care practices, again, no fault of the doctors, have that same 80-year-old patient call and say he's sick and they don't have time to see the patient, so they send them to the ER, right? Like we were talking about earlier. I mean, that feels awful. If you're a physician, you can't even see your own patient for an acute matter. I don't need to convince you that the system needs reinventing. We don't really have a healthcare system in this country. We have a health insurance system. Doctors and patients want the same thing. They want someone to trust. They want to be known, not just for their diagnosis codes, but for their name and who they are. And that's what doctors want too. So let's go do it.
Let's go do it. I know there is more than one thing that you would like people to take from your book, but if you were to pick just one thing, what's just one thing you really want people to take once they close the book?
I'd like you to realize that health is about asking better questions. Like I said earlier, of yourself and then of the people who care for you. So the book is basically like a library of questions to ask your own interior landscape, to ask your family and friends, and then to ask your primary care doctor questions like, what are the risks and benefits of a GLP-1, Lipitor, hormone therapy? Instead of asking, can I or can't I, should I or shouldn't I, talk in a way that invites a conversation, that expresses your understanding of self and how your humanness and humanity relates to the question you're asking and the results you're looking for. Because ultimately, this is a relationship you have, even if it's 15 minutes long with a doctor. And that relationship is foundational to the delivery of good care.
GLP-1s, where do they play a role in your practice and in the care and health of your patients?
GLP-1s are arguably the most sophisticated technology that's arrived in my lifetime. They're extraordinarily effective at helping people with metabolic insufficiency in whatever way that looks, obesity, diabetes, sleep apnea, heart disease. In the right person, they can be transformative. They are not a panacea, however. There are real side effects. There are real downsides. So it's not a one-size-fits-all endeavor. For the patients who have struggled with obesity and all the sequelae of obesity on their bones, their joints, their heart, it's extraordinary. I mean, it's really given people their life back. The most interesting part of the GLP-1s, though, Resa, aren't so much the weight loss, although that's interesting and patients love that when they need to lose weight. It's the insight people have on their relationship with food. So many of my patients who've struggled with weight and obesity, or even just carrying 10 or 15 extra pounds, have lived in this quiet shame cycle of feeling like they're not good enough or they can't do it. And when you take a GLP-1 and then realize that, whoa, so much of this is just biology, that some of it is just the way we have been conditioned to approach food and the way food is manufactured in this country to be hyper palatable. That sense of agency people get over their bodies and their relationship with food is extraordinary. And then there are people who are abusing it or taking it for the wrong reasons. But, I'm not a believer in gatekeeping or shaming people. I mean, I think if you want to take a GLP-1, even though you don't meet the FDA criteria, I think that's fine. I prescribe it off label all the time for alcohol use disorder. It's extremely effective in the right person for helping reduce the cravings and the actual consumption of alcohol. And I think it's great for people who know that they just want to be on it for 3 months to lose 10 pounds after they've had their kids. The question isn't should you or shouldn't you? It's what's the context? What are the downsides? What are the upsides for you and only you? Not populations of people, but you.
Lucy, when did you realize you had a voice and when did you start using your voice?
I love that question. It was during the pandemic where I've always been a writer. I've always been like a journaler and a thinker and a communicator in just a doctor's outfit. The pandemic, I started writing the newsletter that I now write for 40,000 people then, just to my patients and my family. And it sort of took on a life of its own. I started putting it out every day for 90 days and then and it just sort of took off. And from that, I became a regular contributor to The Atlantic. I was a regular contributor on MSNBC on Morning Joe. I got to speak in front of congressional committees about pandemic policies. I realized that if doctors aren't speaking up in a global public health crisis and we're getting influenced by politicians and non-physicians, doctors need to speak up. because you saw that politics plus science equals politics. I have a political identity, but I was not using my political identity in the role. I was helping people make sense of a very thorny situation of risk of COVID over here and the risks of the mitigations over here, right? Because just like we've been talking about, there are risks of the virus. There are also risks of the mitigations themselves. And as conditions change and as the virus itself changed, we needed, in my opinion, to adjust our recommendations to the public. And that wasn't happening with nuance. That's when I got my book deal. And that's when I started writing what is now my Substack.
I'd love to leave the audience with 3 small actions, 3 microskills that they can take from our conversation today. So first, if we have audience members that are interviewing, looking around and trying to find a primary care doctor, what's one question that they should be sure to ask?
They should ask them, how do you conceptualize health? Like, is it about my lab tests? Is it about, a certain set of metrics? Is it about eating healthy? Is it about exercising? Like, get the answer to that question. Because if they say that health is about, coming in for your physical and looking good and seeing you next year, that's not your doctor. If they answer the question, what is health to you and how do you conceptualize health? And they say it's about you, the patient, and it's about me being your partner, and it's about us working together and communicating about risk. That's your person.
People that may not have that much confidence, maybe generationally, they're actually intimidated and there's a power differential with physicians, which there is. And I see this in my own parents, that confidence of asking questions somehow stops when they enter the doctor's office. You have really emphasized that people should ask questions of themselves and of their physicians and develop that agency. For someone that doesn't feel that, what would be one small step they could take to start developing that within themselves, their self-agency regarding their health?
Well, the easy answer is read my book, because it gives you a whole set of scripts of questions to ask yourself. I think you need to think about other relationships in your life where you have felt like you couldn't ask questions or you didn't have a voice, and where you gained a voice. And what did that look like? And usually people will tell you that it's when they found the confidence and they overcame some narrative that wasn't actually true, asked anyway. Like what I teach my young adult children is like, you're assuming that if you ask the question to your professor that like they're going to think you're dumb or you didn't do the reading, but actually asking questions is why you're there. That's why we're sending you to college, right? So ask yourself what other relationships have had that power dynamic and when you've gotten over it. And ask yourself what is the limiting narrative that is in your mind, and then fact check it. What is the voice in your head saying to you when you're being told by your inner narrative, your inner critic, that you can't ask a question? Now, sometimes that inner critic is true. Sometimes the doctor is going to say to you, what kind of question is that? Or they're going to look down their nose, and then you have to figure out how you're going to tolerate that feeling or see someone else.
So a third microskill, a third action, when people do have that feeling that maybe this is not the right doctor for them, and maybe they're working with someone that kind of speaks down to them, treats them unkindly, is kind of gruff, and just doesn't make them feel psychologically safe. I do think people don't think they should feel always psychologically safe with their physician. And I really double down on the fact that you should absolutely feel psychologically safe with your physician. What would you say to people that aren't sure where to start in terms of seeking a second opinion or finding another physician?
Well, first of all, I think you need to trust your intuition. If you feel like your heart racing, your palms sweating, whenever you approach this individual who's your doctor, that's a sign. Like, I think we've outsourced our intuition so much to like out here, like physicians and like the medical industrial complex, when actually we have a right to have, as you said, psychological safety in the presence of a doctor. So to answer your question, like, how do you find someone like that? I think you have to just feel how it feels in your body when you're in that person's presence. And you have to listen to how they respond to your questions. Being a patient is uniquely vulnerable, not just because there's a power dynamic, but because you're looking for advice about your body, about your mortality, about your health. You need to understand what it feels like and tap into the cues your body is sending you when you're in a vulnerable position and asking for help. And if it feels unsafe, if it feels like there's some sort of lecture or sermon that's coming at you or a dismissal, they don't have time for you, that's not okay. I am going to die on the hill of saying it's not the doctor's fault. Sometimes it is, but I'm just saying it's just the system. So I'm very loath to like indict physicians. I'm not going to at large. But there are some people who just shouldn't be in medicine. There also should be a system where people can feel safe.
Dr. Lucy McBride, people who want to follow you and your work, what's the best place and way?
The best place is on my website, lucymcbride.com. And then if you want to, you can find my book there, or you can find it on beyondtheprescriptionbook.com. And then you can find me wherever, you can find the book wherever you buy books. You can find me on Substack. But lots of places to find me.
Yeah.
And I hope you do, because I think one empowered patient at a time is required to create a movement to change healthcare in this country. I think it's possible. I think it requires people knowing what they deserve and advocating for themselves and demanding what is right in their healthcare.
Thank you so much for joining me on the Visible Voices podcast.
Thanks for having me, Resa. Thank you.
The Visible Voices podcast amplifies voices in the healthcare, equity, and innovation spaces. Our team includes Dr. Giuliano DePortu and me, Dr. Resa E. Lewis. Find me at Resa E. Lewis, MD on social media, or visit thevisiblevoicespodcast.com. Find us wherever you listen to podcasts and watch our episodes on YouTube. This podcast is for education and entertainment purposes only. The views and opinions expressed by hosts and guests are their own and do not reflect those of their employers or institutions. Guest appearances do not imply endorsement of any product, service, or organization. Information shared here is intended for general informational purposes only, reflects the time of recording, and should never substitute for clinical judgment or individualized medical advice. No physician-patient relationship is created by listening to or watching this podcast. Together, we're making healthcare more equitable, one visible voice at a time.